Hi everyone, this is the 212 opioid analgesics, or opioid narcotics as it's called in the D2L. We're going to continue talking about this as sort of an overlap. If you remember anything from your 112 opioid analgesics, it's going to be a kind of review overlap with a few extra things. So we're going to review the opioid receptors in the CNS. Remember, we learned about those in 112. We're going to compare actions of the agonists, antagonists, and antagonists. So three kinds of actions there. We're going to compare and contrast the actions and adverse effects of opioid and non-opioid analgesics, and we're going to talk about the action indication, contraindications, and adverse effects of opioid analgesics. So first we're going to talk about the receptors, the opioid receptors. There's three. There's the mu, kappa, and the delta. The ones we care about are mu and kappa because those are the ones that have any analgesic properties when these drugs are activating them. And the delta doesn't have any activation by the opioid. So it's just down there as a, yes, there's three, but we don't care about delta. So the mu is the one that has high efficacy. When we're activating it, it's primarily the main one that provides the highest degree of analgesia effect. Respiratory depression is the biggest adverse effect with the mu receptors. Also euphoria, that's why opioids are abused, because of the euphoria effect you get, and sedation, it causes sedation. The kappa is a moderately activated actions. Most opioids that work on it have a lesser efficacy in pain relief. With a drug that's mostly kappa receptor activation, you get some analgesia and some sedation. Also, you get psychomimetic actions, or is that what that word says? Psychomimetic. So you get hallucinations, you get some altered perception, but this isn't the euphoric kind that causes abuse. It's a not pleasant altered perception, and that actually turns out to be a deterrent for abuse of these kind of drugs that are acting on the kappa receptors. So lesser than the opioids as far as activity. And then the delta, there's nothing, we're not talking about delta because it doesn't help with anything to do with pain relief. Okay, so the opioid classifications, we got agonist, which is morphine, which is a strong agonist, and then codeine, which is a moderate one. They're the prototypes, but codeine actually breaks down to morphine, and so morphine is the basic prototype we're talking about. Then you have the agonists, antagonists, which produce some analgesia by itself, but also can block the other receptor. So like one drug, pentazocine, is an agonist to the kappa, but it's going to block at the mu receptor. So the morphine that you may be taking at the same time isn't going to be activated as well, because if you have pentazocine on board, it's going to be blocking mu, so morphine can't work on it. So the antagonist side is blocking mu, and the kappa side is being activated with that pentazocine. So, like for overdose of opioids, sometimes this is going to happen. The pure antagonist is the one that blocks both the mu and the kappa, and that is used for the overdose. I don't know why I was rambling about overdose already. The overdose side goes with this last category of antagonist, because it's going to block both the mu and the kappa, and your medication is naloxone or Narcan, and that, when given, totally stops the action of the pain relief and sedation that you have received. Okay, so let's talk about morphine. Morphine mimics the action of the endogenous opioids, primarily the mu, but it also activates mu and kappa. It alters the perception of pain. So NSAIDs work peripherally to suppress sensitization of pain receptors. So the pain isn't made, so it doesn't signal the brain, so the perception of pain doesn't make it to the brain. But morphine works on the brain, and it tells the brain to ignore this perception of pain. So it's an effective medication for severe pain. It has a high level of efficacy, especially for cancer pain. For severe pain, it's a cornerstone. It's very effective for severe pain. So it's used for analgesia, sedation. It helps with pain and makes you sleepy so you can rest while you have the pain. Helps reduce both of those things, or give you sleep while you're getting relief of your pain. The adverse effects we talked about already. One big one is respiratory depression. Also, it has vasodilation effects. It slows the GI. It can make urinary retention. It's also used as a cough suppressant with that respiratory depression. So that could be both an adverse and a good use of it. So if somebody has COPD or pneumonia and you want them to cough, morphine is going to be suppressing it, or codeine would be suppressing it. So that wouldn't be something you would want for one of those kinds of patients. It can also cause biliary colic, nausea and vomiting, especially if you give morphine IV push too fast, can cause nausea and vomiting. Dysphoria, euphoria, feeling weird versus feeling good, meiosis, itching. The fairly common problem is itching. It doesn't mean that it's allergy. A lot of people get really itchy when you give it because it has some histamine release issues, but it's not a full-blown reaction. A lot of times people have diphenhydramine or Benadryl also prescribed because they know this is a common thing. So if somebody says, oh yeah, I got morphine before, but it made me super itchy, especially around the nose and face, it seems like a lot of people get itchy on the face. It doesn't mean that they're allergic. It just means that the activity of that drug makes histamine release and it causes this little bit of itchiness. Okay, so let's go to routes. There are a lot of routes: oral, IV, IM, sub-Q, epidural, intrathecal. It's got a lot of routes. This is one where it has the first pass effect, so it might require higher doses orally, because if you remember, the first pass, as it passes orally, goes to the stomach and gets absorbed to the small intestine, so then it gets in the bloodstream, it routes through the portal vein, and then it's metabolized significantly after that. So your dosing might be having to be higher orally because so much of it's getting metabolized with the first pass. With the IV doses, you might see more like 2 milligrams or 4 milligrams or even 8 milligrams, like IM might be a bigger dose. And at home, like somebody with home health care and cancer pain, they might be as high doses as 20 milligram tablets. So also with higher doses, when you need pain medicine, tolerance builds up, and then the first pass thing is happening, so home doses might be even higher. There's a table 25.2 about equal analgesic dosing, and this is really helpful to be dosing in the hospital where they have a very high dose because of the route, and then they're switching them to PO, so it's convenient to help estimate the amount of drug to keep the same level of pain relief. Say you were getting 2 to 4 milligrams of morphine IV, or you were using the PCA, and then they only drop you down to 1 Vicodin. That might not be a really good help for your pain relief when you go home on just 1 Vicodin. So that's a helpful thing for practitioners to know about, getting that equal amount of pain relief for the patient. So also it's metabolized in the liver. So if the patients have liver problems, they're going to have issues. A greater risk of toxicity, increased adverse effects. There's also tolerance built up to the analgesia and to the respiratory depression, to the sedation, the euphoria, which is why people abuse it. And you can get cross-tolerance to other opioids. But a cancer patient might be taking morphine over a long period of time, and they may need higher and higher dosing, and that's okay because that's what they need to take care of their pain, and they're going to have some of this tolerance built up. You still need to do your assessing for level of sedation, what's the respirations like, respiratory depression, and be aware of this tolerance. Let's see. So you might have cross-tolerance to other opioids as well. So this patient who may be taking a lot of morphine at home for their cancer pain, they have to come in for some procedure or surgery, and then they get hydromorphone or fentanyl, some other version in the hospital, they might have to have quite a bit higher dose because of this cross tolerance that they've already built up with morphine that crosses to the other forms of drugs. Okay, and then let's go on to physical dependence. This is a common concern from patients and some caregivers. There's quite a few myths around this about addiction. Basically, with short-term use, and the reason you would be using opioids like morphine for that moderate to severe pain at a short-term use, there's not a concern with addiction for that. And that's a teaching point for you with patients, and to make sure you're listening to the patient about how much pain they say they have, because they're the best historian of their own pain and their own issue. The issue might be possible with somebody who's already has a history of addiction and then receiving morphine or some other opioid. That might be an issue for that particular person, and then the practitioners would have to be aware of this and just treat the patient for their pain and really, support them and give them what they need to take care of pain they may have, and hopefully they can deal with their addiction issues as well. People believe they have pain, so you have to believe they have pain, and you need to rate it. You need to provide them pain medicines and take care of that pain, and you need to teach them about the addiction issue, that it's not, when used properly as prescribed for short-term moderate to severe pain, it's very effective at providing pain relief, and you're not going to be addicted. So if somebody is having withdrawal of this physical dependence that they might have built up, they might have symptoms that include yawning, sweating, to anorexia, irritability, nausea, vomiting, diarrhea, abdominal cramps, and kicking movements of their leg. And some people think that that's where they are calling kicking the habit, because there's these kicking movements. So withdrawal isn't dangerous for the most part, but can be uncomfortable. And so you treat by giving longer-acting opioids to treat withdrawal. Like methadone is one that can be given. It's not as strong, but it provides time to taper the dose down. So, and it stays in your system longer. And so, methadone can be used for pain, but it's also usually used for trying to taper somebody off of addiction. If you're using it properly, rarely are you going to have addiction or abuse when you're using it properly for severe to moderate to severe pain. Okay, some opioid drug interactions we have with antihypertensives. We know that you're going to have added blood pressure lowering effects from the vasodilation, like with morphine, along with whatever antihypertensive you're taking, so you can get a dual blood pressure lowering problem. Anything with CNS depressant effects, like the benzodiazepines, you have additional respiratory depression, additional sedation. With the anticholinergics, like the tricyclics, antihistamines, you get additional level of sedation. You get a potentiation of constipation, additional increased risk of urinary retention. Let's see, with antagonists, you can initiate withdrawal effect, like using pentazocine, which activates the kappa as an agonist, and a mu antagonist. If you're giving that and they were taking morphine, and then you add this pentazocine to try and change one drug out for another, the effects of the morphine from the mu, it's going to be totally blocked, and it might cause withdrawal symptoms from the morphine. So you have to be real careful when switching opiates on people because of these different kinds of agonists or agonist-antagonist on these receptors. It can actually block one and cause a withdrawal symptoms. All right, then we're going to go to fentanyl, also Sublimase or Duragesic. It can come as a lozenge as well. It can come the patch, that's what the Duragesic is. Sometimes the patch is the slow dose. They can all have a rapid onset depending on how you're giving it, but it's different from morphine. The pain relief is very quick, but it lasts only maybe 20 to 30 minutes, especially with the IV route. It's very potent. A dosage of fentanyl might be 75 micrograms versus morphine is 2 milligrams per hour. So it's got the short duration. It's a very potent drug. It has a higher potency, rapid onset, and a shorter duration than morphine. We want to use this drug in like procedures where you want sedation and pain relief kind of quick and over a short period of time, like hard dressing changes that are really painful for the patient, or before a procedure, like say somebody's going for a bronchoscopy, or they're going to have, they know they're being intubated for something or other, they might use fentanyl for the pain relief and sedation just because they know it's going to wear off quickly and act quickly. So you still want to assess their pain, any change in intensity, quality, duration, and it might not mask their pain as significantly as morphine, so you can really get a good handle on how their pain is going. It comes IV, IM, PO. The patch takes longer, up to 72 hours, and then you would change it. Now this is some important thing about the patch. Make sure you remove the old patch when you put on the new one. It still has drug available in it when you remove it, so don't touch it. Use gloves, fold it over, dispose of it properly so other people looking to abuse drugs can't get a hold of the patch. You know, there's still drug left on it. So if you don't remove the patch, patient comes in and they're overly sedated and they have like 4 patches on because over 4 days they never, or over however many days they never change their patch. So that's important. The lozenge also is there that gets absorbed pretty quickly, but it lasts a little longer. This one shows a lollipop in the picture there, but or whatever. I don't know if it's a sucker. I would call that more than a lollipop, but whatever. Taking it in by a lozenge form, so you get a little bit longer effect once it's absorbed. All right, other opioid agonists. We're going to talk about meperidine or Demerol. You may not see this used that much anymore. It has toxic metabolites. It has increased. It increases your risk for seizures, and there's many other safer choices of drug to use than Demerol, meperidine. Then methadone. It comes oral, liquid, and tablets. It's got a longer half-life. It may be used for chronic pain, but this is the one we see used more for opioid addiction, to help people taper off their dose when they're trying to function as a person still and be able to try and get off of their opioid addiction. And then codeine. Codeine is used mainly for a cough suppressant. It's metabolized to morphine. It's a very effective cough suppressant, and it's used also for mild to moderate pain, but it's not very effective for that pain relief. There's better choices again. Okay, and then we're going to talk about pentazocine or Tolwyn. This is an agonist for kappa receptor and an antagonist for the mu receptor. It has lower analgesia effects, has a lower risk for abuse because there's less respiratory depression with it. It's effective for pain. The advantage is a lower risk for abusing it because of that dysphoric altered perception that's not pleasant. People don't like it, so they tend not to abuse it. Higher doses even make it even worse, so it really turns people off to trying to abuse this drug. There is a form called Tolwyn NX which has Narcan in it to get pain relief, and the Narcan to continue to block the mu receptor, but it doesn't have any effect PO-wise. It just gives you pain relief and no blocking of effects with the Narcan. I'm not sure why that Narcan blocking is in there, but anyway, if this is there's other drugs to use. Just be aware that there's a NX version, which is a long-acting version, the version with Narcan added to it. So then some others that are agonists, antagonists are nalbuphine, and that's a weak mu receptor antagonist, and a kappa agonist. And it blocks mu like Tolwyn, but buprenorphine is another one. It's a partial agonist against mu receptor, so not as much pain relief as morphine, but some pain relief, some sedation, some respiratory depression with that mu receptor. That was buprenorphine. It's an antagonist to the kappa receptor, that one is. Okay, let's do some administration assessment issues. You always want to think about their pain level, check their pain quality, ask history about other drugs, how about their alcohol intake. Do they drink a lot or a little, or do they maybe have this cross-tolerance issue? Any CNS depressants at home, then they can overdose if they take the pain medication that you're giving them as well as what they do at home. If they've been on opiates for a long time, we're going to expect that they're going to need higher doses because the tolerance is going to be built up. So for planning, with the opioid naive people, you want to start with much lower doses, or with older people who aren't metabolizing as well, you're better off to start with a lower dose. You can always give more. It's harder to take back what is already given if you've given too big of a dose. For implementation, PRN dose is not as effective as planned scheduled doses and use of a PCA. It's good, provides safe pain relief. It's very effective when used that way. So you always want to evaluate their pain level, their respirations, their level of consciousness, their level of sedation when you're giving medications like this. And then we're going to talk about opioid toxicity. How does this happen? Either we gave too much, or they took too much Narcan. They took too much, we gave too much, or that's how it happens. We give too much, or they took too much. Narcan is the easy fix, but we want to remember the basics. The adverse effects we know are going to be respiratory depression, hypotension. So when they're not breathing well, our actions that are basic are going to be support respirations, give oxygen, make them deep breathe. If they're hypotensive, from the vasodilation effects, we might give them a fluid bolus. We might then think about doing Narcan to block the mu receptors. It might not last as long as the narcotic that they've actually taken, or the opioid that they've taken, so you have to keep reassessing them, because it will, the Narcan will block the receptor, but then as that Narcan wears off, or the naloxone as it wears off, then the opioid is going to be working again on the mu receptor. So we have to keep frequently reassessing them, and know that we might need to give another dose of Narcan or naloxone again. Watch their respirations, watch their drowsiness. If we see that those two things are increasing, then you got to think, oh, the naloxone has worn off and the morphine is acting longer than what I expected, so go ahead and see about giving another dose of that naloxone. Okay, now we're going to talk about tramadol, or Ultram. When this first came out, they said there's no issue with sedation, it's just a centrally acting, but now they know it does have some addiction properties. It's a centrally acting opioid analgesic. It's a weak agonist for the mu receptor. Some places it says 1/10 the effect of codeine. It also binds the serotonin and norepinephrine reuptake. So SNRI, it inhibits that, so it modulates the pain signal in the spinal cord. So the mu receptor, it's acting on the mu receptor, it tells the brain to ignore the pain, and then it modulates the effects of the transmission of the signal up to the brain. So you get both that dual effect of pain relief, of blocking the signal and ignoring the pain. It's good for acute and chronic pain. Some adverse effects are going to be the CNS effects of excitation, nervousness, anxiety, confusion, and agitation. This might seem odd, but remember the serotonin, norepinephrine reuptake inhibition effect. That's stimulating, those are two stimulating neurotransmitters, the serotonin and the norepinephrine, so that's why you get those excitations effects. It also lowers the seizure threshold, so if somebody has a history of seizure disorder, they probably shouldn't be taking tramadol with that. And then rarely you can get some CNS depression. If you add alcohol to the situation, you can really add to the CNS depressant effect. And then there's a risk the FDA has put out for suicide and addiction for those who are at risk for this. So it's not good for not good choice for those people. Say the patient is telling you that they've had issues with suicidal thoughts, or that's something you might be teaching them, that Ultram is not tramadol is not a good pain medication for them to be using. It is not approved for pediatric use. However, remember back in 112 when they're watching for which medications work for children, what they found is it has a bad effect, a difficulty breathing and slow breathing after surgery, especially tonsil or adenoid surgery in pediatric population. So there's a med watch for tramadol for the pediatric population and surgeries where they're getting surgery and tramadol is being used with that population. So this was a pretty quick one. We covered everything, and I'll talk to you again soon. Thank you for listening.